All right, we're going to get going and have Dean Ambrosini, my colleague in East County, get us started. So I'm going to end the poll now. Thank you to everyone who participated. And Dean, do you want to take us away?
Sure. Good afternoon, everyone. Thanks for joining us today. I'm Dean Ambrosini. I'm a prevention specialist with the Institute for Public Strategies. IPS is a prevention provider contracted with the County of San Diego Health and Human Services Behavioral Health Service to help build healthier communities and address the issues which contribute to substance misuse. IPS was founded in 1992 and recently underwent a change in leadership, which brought with it new core values and a renewed commitment to equity in the communities we serve. Our core values are equity, diversity, empowerment, systems change, results, and integrity. At the top of the list is equity. For IPS, equity isn't just a path forward, it is the path forward. IPS has two regional contracts in San Diego County, the East County Community Change Project and the South Bay Community Change Project. Within those regions, we have special focus areas which are dedicated to substance misuse prevention and community building. One of our projects is the Overdose Data to Action Project, which is our response to the opioid crisis. I'm the project lead for this project in East County, and my partner, Rain Henke-Ledwith, is the lead in the South region. IPS uses an upstream approach to prevention, which means that we address the systems and policies which contribute to substance use. We work alongside communities to build power, challenge systems of inequity, and protect health and improve quality of life. We've applied that approach to our opioid program to address the inequities and disparities in our region, which are fueling the opioid epidemic, and act as barriers to treatment for those who misuse opioids. Of all of those barriers to treatment, stigma is the most damaging. Stigma influences how we feel about a situation or person, in this case, opioid addiction. We're going to do a quick polling question. What percentage of those needing care for substance use disorders don't seek it due to stigma? Rain, do you want to go ahead and launch the poll? Quick answer.
All right, we're about 50%. Let's get a few more answers in. About 80%, if you can get everybody else to chime in. And just a few more. All right, I think we've got it. And let's share the results.
We had a good variety of responses, but the actual figure is 25%. 25% of the respondents to the survey who need or were seeking treatment for opioid disorder were hesitant to do so because of the perception they had of opioid addiction and the fear of what others might think. But this doesn't include those who measure themselves against these perceptions, believing that their opioid use is not that bad and continue forward until they succumb to their addiction or overdose. So the ones that answered that it was slightly higher or higher could be correct, because we really don't know the actual answer to that question, unfortunately. I'm now going to introduce our speaker for today. Katie Bell is an addictions nurse who has been working throughout the state of California, supporting the building of medications for addiction treatment programs in primary care clinics throughout multiple grants. She's been involved with Tribal MAT, supporting tribal and urban Indian health clinics. And I'm now going to turn it over to Katie. All yours.
Hello, hi everybody. Thank you so much, Institute for Public Strategies, for inviting me to talk today about one of the most important aspects of responding to our current opioid and stimulant use disorder epidemics. And my purpose today is to really connect how stigma impacts the human beings whom we are trying to help. So imagine what it is like for a person who has suffered from a severe substance use disorder for decades, encountering stigma at every door. A secondary injury has occurred from the seeking of help, a stigma, wounding, or injury. I'm going to be covering quite a bit of ground in the next few slides. I'm really hopeful that we can have some time for questions and answers and comments. And at the very end of this slide set, we're going to do kind of a case study of someone who is a composite of what stigma actually looks like in the world of care. So the common feelings behind stigma are often unexplored and unspoken, but there's a reason why stigma has such a powerful punch in terms of obstructing care and funding. So very common, almost every family has someone struggling with alcoholism, very common and severe substance use. There's this, it's genetic. So I come from an Irish family. Alcoholism is pervasive. It's been part of the family story since I could learn to think about who we were as a family. And there's always this family shame, this family secret, and a lot of anger that, is one of the consequences. So there's frustration. Why can't they just stop? It's a baffling and frustrating illness to treat. Relapse is part of it. It's often disappointing and devastating. There's fear, especially around the high risk of heroin and fentanyl in our communities. We're so afraid that we're going to lose a loved one. Hopelessness is often what our patients carry into the door with us. And there's a lot of grief around the losses. 12-step cultural and religious rules. Often the perception is that this is a sin or a moral failing. So reframing substance use disorders in the treatment is a really big task. Also, the consequences of continued compulsive use can be difficult and destructive. Loss of family, loss of children, loss of freedom. So it makes us sad, it makes us fearful, and it makes us angry. And it's important to understand and validate that those are real feelings. Now I'm going to shift a little bit to a guide to acronyms and terms. MAT, we say MAT now. We change it from medications for assisted treatment to medications for addiction treatment. So we're moving into a broader scope of care. And some say mood, medications for opiate use disorder. Mostly we say opiate use disorder now, so that when you see OUD, that's pointing to that. And we are now really expanding our programs, our grants, and our care approaches to include stimulant use disorder, all substance use, but stimulant use disorder. So if you see this stud word, it means stimulant use disorder. Stigma is the core of this conversation today. It's a barrier to care communicated by language, judgmental attitude, and because of this judgment, decrease in quality of care. And the word misuse has replaced the word abuse, or we're replacing it. Taking more than prescribed, using non-prescribed opioids, including injectable heroin and fentanyl, are all descriptions of misuse. So often you'll hear addiction, or you'll hear substance use disorder. So addiction is kind of a term that we use in medicine. has been identified as a chronic, progressive, relapsing disease or condition, and is treated medically. And you'll hear there's the American Society of Addiction Medicine. I'm an addictions RN. Doctors who become board certified in addictions can be called addictionologists. And then we can go across the hall to behavioral health, and we find the term substance use disorder, and is identified in the DSM-5 and measured in a continuum of mild to moderate to severe, and very specific to the substance being misused. We don't really say polysubstance anymore. We identify each of the substances specifically. The mild to moderate to severe continuum is familiar to behavioral health because we also use it in identifying behavioral health care and levels of care. So it's very helpful. Dina's going to now read just a piece written by Dr. Corey Waller about opioid craving to give us a better understanding of what we are meeting and treating.
We need three things to survive besides oxygen: food, water, and dopamine. If you deprive study subjects of water for 3 days, then put them in a functional MRI and place water on their lips, the relative size of the craving is like a baseball. Do the same with food, and it's like a basketball. Then take someone with an addiction to opioids up to 1 year after their last use and talk about OxyContin while they are in a functional MRI, and the relative size of that craving is the size of a baseball field.
Thank you, Dean. So here it is. Baseball is food, basketball, water, and just thinking about OxyContin is a baseball field. So when we say, why can't they just stop? This kind of gives us an idea of the intensity of what's going on in the brain of someone who has opiate use disorder. Also a distinction that's really important: opioid dependence plus behaviors equals the opiate use disorder. So opioid dependence is physiologic, which means that there's tolerance, which causes the need to increase quantity to sustain effect. And then there are withdrawals when the opioid is stopped. And an important way to frame this understanding of dependence is there are often people who have been treated with long-term opioid therapy for chronic pain, who take as prescribed. They would probably, they're physiologically dependent, but it's the behaviors that would identify that as an opiate use disorder. And really important is when a baby is born to a dependent mother, they are not born addicted. We don't use that. They are born with neonatal abstinence syndrome, and they are born dependent if we're going to talk about them. So let's not stigmatize our babies. So addictive behaviors involve misuse, such as, and I want you to think about that baseball field. Involve misuse, such as taking more than prescribed or continued compulsive use in the face of increasing consequences to health and wellness, diversion and relapse driven by craving and triggers. So it is behaviors. You look for the behaviors. Let's say someone who has been treated for years with opioids for chronic pain, and they begin to take more than prescribed, run out early, turn to friends and neighbors, to that now we're on that continuum of behavior. It's important to identify, provide care. Understanding trauma as a root cause of addiction. The question is not why the addiction, but why the pain. And this comes from Gabor Mate, who has been a real advocate of understanding trauma and addiction. The source of pain is always and invariably to be found in a person's lived experience beginning with childhood. So we now use the adverse childhood experiences screening at intake. We ask about adult trauma related to lifestyle of drug and alcohol use. And really important when we talk about trauma-informed, the key is people with trauma need to feel safe. And why would opioids be specifically connected to the symptoms of trauma, PTSD? Opioids change the perception of pain. This includes the numbing of physical pain, emotional pain, and mental anguish. People with untreated trauma can self-treat, let's not use self-medicate, their pain with opioids. It's really important to understand that if we're looking at severe opiate use disorder, we are also looking at usually untreated trauma. Stigma is our biggest barrier to ending the opioid epidemic. It's shaped by our thinking. It's a bias and a perception that substance users are bad and immoral rather than suffering, with a chronic condition requiring care and treatment, communicated by words, language, tone, interpersonal attitude, indifference, and body language, and becomes internalized by the person seeking help. The person begins to view themselves as bad or weak. The shame fuels their sense of hopelessness, and they become convinced that not only do they not deserve help, but they won't get it when they reach out for it. This is why we have so much dying around this particular addiction. Stigma is in many forms. We're going to cover this quickly. It's institutional and structural. It's part of the political will and the funding. There were years of this escalating epidemic where there was such a slow response that by the time the money arrived to start responding to the epidemic, there had been such a spiraling for our people. If they hadn't died of overdose, they were often now found themselves homeless and separated from their families. So the slow response has really impacted our ability to make changes. Medical care settings, contempt, decreased care. Emergency departments have up until recently been really a vector of stigma directed at people with substance use disorders. Primary care settings, often providers have no idea how to even have a conversation about substance use disorders. All of that is changing. California Bridge program is one of the biggest game changers in our state because emergency departments have now become places of welcome. Law enforcement and justice system, jail without drugs and alcohol treatment. Someone will go through withdrawal, which can be old school and unkind. That also is changing, but we need to go, we need to quicken the pace. Stigma is also in cultures and families. We talked about that a little bit. Substance use treatment settings which have been mostly 12-step informed, and don't get me wrong, I love the 12-step world. And I am a part of that community, so it needs to make some changes so that more people can find a spot in the room. When are you tapering off your Suboxone was often a common part of the counseling care. So the perception, 12-step groups more accepting but not considered clean if prescribed methadone or buprenorphine, which is Suboxone, for opiate use disorder addiction. So I just wanted to put this here. The Medication Assisted Recovery Anonymous International is a wonderful place for people who would like to be welcomed into a 12-step community while being treated with medications for their addiction. Contributes to poor care. I'm just going to touch on this briefly. Health professionals may have an avoidant approach to delivery of care with substance use disorder patients compared to other patient groups, may result in shorter visits, expression of less empathy, and less patient engagement and retention. I have to say that in all my years as an addictions nurse, that I've had so many patients just say, don't make me go to the ER. Or there have been times when I have called the ER and I said, I'm bringing them over because they needed an advocate to actually enter the ER space with someone who would intervene on stigmatized care. Some of the language we no longer use is probably the most important slide. Believe it or not, we are getting rid of the word abuse, as in substance abuse. Was identified in the medical lexicon as the only diagnosis which had the word abuse. Misuse or use is the correct replacement. And we also do not use the word addict, except maybe in the 12-step rooms where it's part of the culture at this point. Rather, we use person-first language. And I have a feeling that most of the people I'm talking to already understand and utilize this shift. Person with substance use disorder, or people who inject drugs, or people who use drugs is a good example. We no longer use drug seeking or med seeking, which is a very common term, can be reframed as relief seeking. This shifts the focus on the person, on the human being, rather than the behavior. We no longer say needle exchange. A less stigmatizing phrase is syringe exchange, which is an essential aspect of harm reduction. And we use people first language, people with diabetes instead of diabetic, person with schizophrenia instead of a schizophrenic, people who use drugs, a person with alcohol use disorder is a good example. And we never call a medical lab result clean or dirty. This is probably one of the most common ways that urine drug screens are talked about. They're clean or dirty. We always use medical language. We would never sit with somebody and say your A1C is dirty today. We just understand that this is a lab result. And using street language in medical settings or in treatment settings is really often not the language of dignity, which is where we're shifting. If we say positive or negative, we say positive for opioids, positive for methamphetamine. The stigma injury. So after years of stigma in settings designated for care, a person will not seek help or hesitate or to seek help, and even basic medical or dental care is not sought or delayed. Symptoms can be fear of emergency departments. I just described that. Distrust of medical providers. I'm never going to go tell my doctor that I have a problem with alcohol. Very common. Feelings of shame and dishonesty, less than forthcoming about behaviors because of stigma. If not treated, the person internalizes the shame and low self-worth caused by stigma. So here's the good part. How do we treat an injury like this? Openly and directly acknowledge and validate the experience, let's check the time here, of stigma and how stigma has contributed to their suffering. I've done this with all of my patients in the last many years. I really validate the experience. Humility expressed by medical providers. It says, yes, we have work to do. We are part of this problem and we're going to change. This kind of acknowledgement and validation, rather than gaslighting our patients, is a balm to the stigma injured. Really builds a sense of trust and safety and openness. The language of dignity begins with listening, followed with respect. Develop trauma-informed care and understand that stigma itself is traumatizing for people seeking help. For some, it has been decades of disrespect, harsh judgments, and minimal care. Stay focused on the human being. Bring respectful, compassionate interventions. Often we really need to do very direct interventions on behavior and it always has to be respectful. Partner with our patients, build a trusting relationship, and support autonomy. Keep the doors open to care in the face of relapse. Whenever I would meet with a new patient, I would say the first thing you need to know is no matter what happens, this door will always be open to you, which acknowledges that things could change. Maybe they're motivated today, but not 6 months later when they've had some kind of slip or relapse. Doors always open. This is how we treat it. Now we have a kind of a composite patient. I've heard and seen all of this many times. And Rain is going to read a little bit about Allie's case today.
Allie is a 19-year-old woman presenting to the emergency department in her small hospital in her rural community with complaints of severe earache. Allie has hesitated for days to seek help as she overheard a staff member refer to her as the addict in Bay 3 at her last visit there. This is the only hospital in her small town, and she has been coming here for emergency care most of her life. Recently, she has had more visits, including treatment for a heroin overdose about 6 months ago. As she is brought to her bay in ER, she hears someone on the staff refer to her as a frequent flyer. As the new RN reviews her chart and her current symptoms, she sees a recent positive test for pregnancy and asks if she is still, quote, shooting drugs. The wait for the MD to see her is long, and she's beginning to feel the onset of opioid withdrawal. The lab results return, and when the MD comes in, he begins with, quote, CPS will take your baby if you don't get clean. Your drug screen is dirty today. Now, why are you here today? MD prescribes antibiotics for ear infection and refers her to follow up with her primary care.
So I'm going to stop the screen for a minute. I would love to just go use the chat to kind of identify what kind of stigmatizing language or tone was used in Allie's visit to get her earache treated, and maybe things that were missed. So go for it, right into your chat. I'd love to hear from you. Really good. Shaming language, shooting drugs, frequent flyer, dehumanizing language, threats with CPA, taking child, using dirty and shooting drugs. Exactly. No compassion. And not referring her to treatment. Huge. Hello. Yeah. So what was missed? She was given antibiotics. And, you know, if there was a trained caring person, they would probably see the onset of the withdrawal, offer Suboxone and treatment, no implied care. Yes, all of that. So this is what she encountered. What if a week from now, her ear condition has, after completing the antibiotics, has gotten worse? Do you think that she's going to go back to her one and only hospital to get more care and more evaluation? Any thoughts on that? Yes, nonetheless, absolutely necessary. So powerful to understand the impact. Imagine if Allie has struggles with relapse over time, she's absolutely not going to go to the ER. I've had patients sit in my office and just cry because they have to go to the ER. Don't make me go. I would rather die. When you hear something like that come out of a patient's mouth, I would rather die than go to that ER. We know that we have to change. Now, the bright side is the California Bridge to Treatment program is hanging a huge welcome sign. You know how we say there's no wrong door, addiction treatment starts here. Well, we need to make sure that every one of those doors is not only open, but it says welcome. Come on in, let us help you get well again. So a recent quote, this is actually someone that I worked with many years ago. The stigma is the main reason we don't continue treatment indefinitely. When we are seen as bad, we want to get good as fast as we can. And when the job is done, we want to distance ourselves from things and places that make us look like bad people. If we can be seen as sick and brave for fighting a terrible and fatal illness, our numbers would be so much better. So that was from Steve. No more stigma, no more shame. PSA real quickly, the presence of fentanyl is on the rise in all of our communities. Make sure that you, wherever you're working or wherever you stand, the goal is to have Narcan in every backpack, in every purse, so that we can respond to the increase of overdose, especially fentanyl overdose. A few things about fentanyl is it's mixed with other substances such as methamphetamine, cannabis, heroin, street pills. So often our patients do not know that they're using fentanyl when they are using their drugs. So there are fentanyl strips so they can test it. It's 5 to 100 times more potent than morphine and can require up to 6 doses of naloxone to reverse an overdose. California Naloxone Distribution Project, you can go online and order for your agency. It's really easy. And Narcan Now is an app, has a complete training. It has a 991 button on it, and everyone who has a smartphone should have a Narcan Now app. I'm not promoting a pharmaceutical, but I am promoting the use of naloxone, and Narcan is kind of the one. It's kind of like Suboxone, which is also a brand name. So if you have any questions about this, please reach out to me. And here's some references and links. Really good articles here, recent articles, all of them published this year. Here's the Naloxone Distribution Project, the MARA International, the Bridge to Treatment, and that's me. And I really, really appreciate your time today. I know you're very busy people. Thank you.
And all of these slides and contact info and the recording of this webinar are all going to be available to you in a follow-up email.
We're going to open up the floor for questions. If anyone has any questions for Katie, if you'd like to put them in the Q&A, we'll go ahead and have them answered live, or you can put them in the chat.
Yeah, and comments. I know there's a lot of wisdom out there, and I'd love to hear your comments.
Katie, I had a thought while people are formulating their questions or comments. Did you want to speak to that first poll about the stigma survey?
Uh, yeah, but I'm also getting some questions
Right.
I wanted to
Okay,
respond to.
go
What
for
was the
it.
medication that was recommended? Are you talking about using buprenorphine or methadone? Is that your question, Ms. Nelson? I guess, yeah. Best practices being implemented in other parts of the country that aren't being used here. Well, you know, that's a great question. California is really a leader. They turn to us a lot. The state of Vermont, which is my home state, really developed a hub and spoke program early, and California kind of learned from Little Vermont. So best practices are still being identified in a lot of ways, but California is doing well. Where can we order naloxone? I'm a mobile fit. Oh yes, wonderful. So go to that last slide or pull up, excuse me, California Naloxone Distribution Project. California Naloxone Distribution Project, and there's everything you need is to get that, and you can have piles of it in your office. How do we begin to build trust with so many years of stigma injury? We begin by, I always began by just acknowledging that it was there. I began to see that it was something that needed to be addressed rather than just taking medical history as go, have you ever experienced any stigma because of your disease? And that really, really shifts that relationship. Both
We
of
have a couple of
them.
questions in the Q&A.
Okay, let's take a look.
The first one is from Dan Skiles. Why do we not use the term self-medication?
Oh, I love it. So this is just a personal preference of mine. Because when you say somebody is self-medicating with whiskey, we know that whiskey is not really medication most of the time, or that they're self-medicating with an injectable opioid such as heroin. So it's kind of defining it a little better. I don't have a problem with self-medicating, but I prefer self-treating because that's a little more direct, and it doesn't imply that any of these substances, when they're misused, that they're in any way a medication. So that's a personal preference. Any additional insight on getting the information?
There is another one as well. I'm sorry, I don't want to interrupt the flow.
Yeah,
Yes.
I see it.
Let's see. Do you have any additional insight on getting information out to hard to reach people? What are the best practices being used to address these individuals?
Well, that's such a great and complicated question. And what we're doing here, you guys here and me here, talking about it, identifying as an injury. But I think when the solution to stigma is education, and more education, information, education, understanding that stigma is brutal for people who are struggling with substance use disorder and trauma and behavioral health diagnosis. But also I found that if I started with the validation that there's really big reasons why people are so angry and hateful and judgmental about addictions, that really helps. Often people once that anger is validated, the confusion, the fear is validated, it's a good place to start.
One more here. From Haley Kerbo. In a scenario where a woman is pregnant and using, how would you suggest going about it? It's a touchy subject, so what is the best way to start discussing treatment and recovery?
Right. So we have something called screening, brief intervention, and referral to treatment. where medical professionals have been trained to screen and do a brief intervention. It's really built around something we call motivational interviewing, which is our language in treating addiction. We meet, and really remember this, we meet our patients where they are, but we do not leave them there. So someone who would be trained, if that doctor or nurse or MA had been trained in brief intervention or motivational interviewing for Allie, the conversation would not be a threat from CPS by the doctor, but it would be something like, how concerned are you about your baby and your drug use? That would be the way that we would start, is to, without any judgment in that statement, how concerned are you, would be a good way to start. But there's training out there. SBIRT is available through the state. There's a 4-hour SBIRT training that you can just Google Department of Healthcare Services SBIRT, and it's free.
There's a question in the chat,
yeah, about
Jessica.
Jessica, can we order naloxone as an individual? You can. It's usually an organization, but you can also get it through your primary care. You can get it through pharmacies. I would find an organization that, it sounds like you want to have piles of Narcan in your possession so you can give it out freely. So I would recommend that you directly reach out to the California Naloxone Distribution Project and see if they can help you get that. There we go. A new path in San Diego provides naloxone for free. Awesome.
Thank you.
All right. Any more questions or thoughts?
Katie, I have a question for you. Can you talk a little bit more? You mentioned the language of dignity,
Right.
which I think is a very striking statement. Can you maybe expand on that a little bit more? You talked about it in the presentation, but just dive deeper in there, please.
So, you know, as I have worked through the years with stigma and the big thing of destigmatizing, and I began to go, is there another way of describing non-stigmatizing language in a positive way? And I just, you know, I said, well, I would call that the language of dignity. And I hope that it catches on, because it really reframes the natural response for anybody seeking any kind of care, is that the first thing we offer is dignity, rather than we got to destigmatize. So it's a shift in how we talk to our people and about our people. And there's also been this very common use of street jargon, street language, especially in treatment centers, where it's kind of considered a kind of a way of getting closer to our patients or bonding with them. But often that street language is just loaded with the self-stigmatizing that occurs because of stigmatizing. So I encourage anyone who's offering care to use the language of dignity, use medical, professional, nothing fancy that our patients won't understand, and to teach them to think about themselves in new ways. So the language of dignity is a complete reframing of how we talk to our patients, how we talk about our patients, how we write about them. It is kind of what the next step is past the concept of destigmatizing. That work?
Thank you.
Thank you. Anyone else?
We don't have any questions in the chat.
None in the chat, or none in the Q&As. I think we got them all.
Really wonderful to be a part of this conversation. Thank you so much, everyone, for your time. Did we want to talk about any of the polling results?
Right, right.
Uh,
I actually, Katie, I'm sorry. I do have one more question for you because while you're here, can you briefly talk, because we have a lot of Native populations in San Diego County, can you talk a little bit about the work that you've been doing with them, which may be of interest to some of the folks who are watching?
Yes. So my last 5 years as an addictions nurse was in a tribal clinic up here in Northern California. And when I started working at that clinic, I was informed that we don't treat addiction. And the big shift has happened. We now have programs in primary care settings. The tribal communities have been harder hit. The hardest hit communities are the Native American communities by the opioid epidemic. The proportional overdose rate is astonishing. In California, we have 108 recognized tribes, California tribes. California has the largest Native American population of any state. And then, so we have the tribal communities or reservations or the rancherias up in Northern California, all the way down to the border. Out in Alpine is the Southern Indian Health Council, and out in Valley Center is the Indian Health Council. These are beautiful, patient-centered, tribal focused clinics. Recovery is based on healing the community and using traditional values and cultural ceremony. Very crucial. That's a big part of our work. And I know David was attended something that where we really addressed that. So higher impact. So we need a stronger response. And as every culture has its own version of stigma, there's stigma there and barriers that need to be addressed there. But the big push, we have something called Tribal MAT 2.0. You can also Google that. Multiple projects. I'm a part of that project. What I do is I go to clinics and teach them how to build a culturally centered MAT program. Often these clinics are understaffed, especially if they're remote. So the challenges are both the same and unique. Traditional medicine is very appreciated and supported by the state of California, which really makes us ahead of the larger work. And in San Diego, we just have, there's two types of ways that we define our care. There are the tribal communities with the tribal clinics, and then we have the urban Indian health centers, which often are, they meet the needs of people from many tribes throughout the country. So the best way to respond is to learn, take some time to learn who's in the community and how stigma impacts them in a very specific way. They need a lot of help. The tribal clinics and the urban Indian health clinics need a lot of help. And I think the biggest thing is to be aware. And I'm sure if I'm talking to 41 participants, there are some Native people in this group. I would be surprised, and if they have something to add, I would appreciate it.
Katie, did we want to take just a couple minutes to dig into the results of that first poll, the Stigma survey?
Yes, please. Do you have the results?
Yeah, we'll share them right now. If you want to speak to any of those questions or results, go for it.
Was I supposed to do this, or was another one of the hosts assigned to this? I'll be happy to do it, but David or Dean?
You can
can
see
do it.
the results, right?
Can you
I
see the
can.
results? Okay.
Okay.
Yeah.
So Dean, you want to go for it?
Sure, I'll do it. The first question was, although I don't necessarily agree with them, sometimes I have prejudiced feelings like gut reactions or spontaneous thoughts towards drug users that I don't feel I can prevent. The majority of people said that they strongly agree with that. And second in line was disagree, and some strongly disagree. But overwhelmingly, people did agree with that sometimes those perceptions do exist.
Yeah, that's a nice, honest response.
Mm-hmm. Second question was, I understand the experience of being stigmatized as a drug user. The first answer, the overwhelming answer was that 61% of the people in our group today before this discussion agreed with that.
Wow.
And 30% disagreed. And for the most part, people are having a sense of understanding to some extent. In fact, only 9%, actually, no, I take that back. 39% actually did disagree, that they don't have an understanding, but we do have a larger percentage of people that do have an understanding of stigma. Number 3, sometimes I'm uncomfortable around people who are very different from me. The majority disagree to some extent, either strongly or otherwise. Some, 39% though, said that they are uncomfortable around people who are different. Number 4, I trust drug users just as much as I trust non-drug users. For the most part, people disagreed with that. In fact, 87% of the people either disagreed or strongly disagreed in trusting drug users.
Interesting. Yeah.
Number 5, if a woman is pregnant, she has the responsibility to stop taking drugs. And with the exception of 9% of people who disagreed, people who answered the survey, I can't do the math that quickly, about 91% who responded said that it is her responsibility to stop taking drugs. You can comment on any of these if you want me to slow down.
Yeah, I just think they're an interesting reflection. I don't really have a big comment.
Okay. Drug users have a difficult time practicing safe sex constantly. The exception of 17% of the people who answered, it was in agreement with that they don't believe that people practice safe sex when using drugs. Number 7, drug users have a meaningful participation in developing policies and programs at my organization. For the most part, it's about 50-50. A little bit over half agreed to some extent, and a little under half disagreed to some extent.
That's a very interesting.
It is.
Yeah.
In fact, I wish I could do math quickly in my head and I give it to you, but I know how to avoid language that stigmatizes drug users. And
yeah,
we had 83% of the people said that they do.
They
and
already knew.
Yes, and 17% do not, or did not. Maybe they do now. And our final question, although it's hard to admit, I sometimes judge people who cannot stop using drugs. And that was very close, but most people disagreed and said that they don't stigmatize people. But it was 43% who agreed with the statement and 87%, or no, 57% who disagreed. So
pretty even there. Yeah, yes. Thank you.
Mm-hmm. Right.
Well, I want to respect our time and thank you so much for everyone that participated in that survey and your fearless, honest responses. We have
Yep.
one more survey for you. I'm going to pop it into the chat if you want to follow. That's a feedback evaluation for us. And Dean, if you want to take us out.
All right, great. Again, as Rain said, I thank you everyone for joining us, and especially I thank Katie for speaking with us today. A fascinating webinar, and we talk on a regular basis, and I enjoy my conversations with Katie a great deal. I learn a lot. So I'm glad you guys all got the opportunity to share some of that knowledge. I'm putting up an information with our contact information. Both Rain's and my information is there. If you'd like information about the Overdose Data to Action Project, Katie's information is there as well. If you want to jot down either of our emails and send them in, we'll be happy to provide you with a copy of the slides. We're saving the chat, so we will have a copy of people who asked for them in the chat as well. And this webinar was recorded and will be on our website, publicstrategies.org, within the next 5 to 7 days once it's been edited and put together by our staff. So again, thank you so much for your time today.
Oh, and one quick thank you. Thank you to Andrea for her interpretation today. And thank you to our colleagues, David Shorey and Stella Andrade, for their tech support.
Thank you all.
Thank you.